Good morning, everybody. Today's debate is about neoadjuvant therapy before surgical treatment for intrahepatic cholangiocarcinoma. And I have been given a job to talk in favor of neoadjuvant therapy. That will be a little biased for a surgeon to talk about chemotherapy. An oncologist might have a better option. But after exploring the existing and contemporary literature, I found that there is definitely a room to defend this approach for intrahepatic cholangiocarcinoma. The plan is I will just go through the background and underlying the importance of surgical resection in this malignancy, staging, what is the game changing in GI malignancies and the way NAT has come in many other organs, evidence of NAT in ICC, safety of NAT in ICC, the future trials which are undergoing, and concluding remark to the best of my understanding. So, intrahepatic cholangiocarcinoma or peripheral CCA or cholangiolar cancer or cholangiocellular carcinoma are different names for the same entity. Second most common primary liver malignancy, 10 to 15% of liver cancers, incidence about 0.85 in 1 lakh people, highly variable, more affected men than women, and common presentation is in 7th decade. It is an aggressive primary hepatic malignancy with an overall poor prognosis. 5-year overall survival might be less than 5% if we consider all comers, and surgery is the curative treatment, and the entire strategies revolve how we can take a patient to table and achieve R0 resection and complete lymphadenectomy. So this is what we origin is cholangiocytes within the liver in peripheral bile ducts, but proximal to the second order bile ducts. So we can see here the differentiation between distal cholangiocarcinoma, perihilar cholangiocarcinoma, and intrahepatic cholangiocarcinoma. So this is the incidence of cholangiocarcinoma worldwide. Unfortunately, the incidence is not reported from India or Indian subcontinent. And these are the growth types identified and described by the Japanese surgical study group of liver: mass forming, periductal infiltrating, or intraductal growth type. So coming to the most important is in the next discussion comes is the TNM staging based on the 8th AGCC. T1A is a solitary tumor less than 5 cm without vascular invasion. 1B is more than 5 cm till without vascular invasion, either of portal vein or cava. Then T2 is a solitary tumor with intrahepatic vascular invasion or multiple tumors with or without vascular invasion. T3 is tumor perforating liver, the visceral peritoneum. T4 involving local extrahepatic structure by direct invasion. Obviously, N0 is no regional node metastasis, and N1 is present regional node metastasis. Regional nodes are considered those in the hepatoduodenal ligament, then portocaval region and portal. The stage groups are like 1A when there is T1A, N0, M0. T1B is T1B with N0, M0. T2 is in stage 2. Stage 3A again T3 with no nodal involvement, no mets. 3B is either T4 or any T with involvement of the regional lymph nodes without metastasis. And stage 4 is any T, any nodal involvement with the presence of distant metastasis. So this is very important in coming discussion. Main treatment for ICC is hepatic resection. Technical resectability is ability to perform and R0 margin, negative resection, with preservation of adequate future liver remnant. Free of volumetry is more mandatory. Normal liver at least 30% of FLR is mandatory. Steatosis or cash, then we got expected FLR is higher. And cirrhotics, more the merrier, either more than 50%, more than 50% is expected. Bilateral inflow or outflow involvement, metastatic disease, distant lymph node metastasis are considered absolute contraindication for surgical resection. But if we stage 1 disease or T1 tumor, solitary intrahepatic cholangio less than 5 centimeter with a R0 resection, and obviously no nodes involvement, the 5-year overall survival is expected to be 70 to 75%. But multiple tumors and bilateral involvement is a relative contraindication. But if surgical resection safely can be achieved, should be attempted. Larger and multifocal, more than 2, more likely to need extended hepatectomy, more likelihood for complication, but overall survival and disease-free survival are not negatively impacted. Lymphadenectomy is must, and node positive is the most important prognostic factor. Survival benefit of R0 margin is lost in the presence of N1 disease. Recurrence rate of 93% in node positive patients undergoing R0 resection versus 47% in node negative patients established long back. But there is mixed evidence in both favor and against, but increased survival for node positive patient is also reported, provided they have underwent adequate lymphadenectomy and at least 6 nodes has to be removed from the region of hepatoduodenal ligament. So NCCN guidelines strongly suggest that the lymphadenectomy has to be undertaken. Portal triad structure should be skeletonized in all cases. Right lobe tumors, HDL and portocaval and retropancreatic lymph nodes. Left lobe nodes along lesser curve and cardia of stomach are recommended for lymphadenectomy. Gross involvement of celiac or para-aortic lymph node is considered metastatic and is considered contraindication for surgery. Resection margin, there is importance, and once there are papers that as the resection margin is larger, there is a better survival. If there is survival of R1 plus N1 is equivalent to R0 and N1, survival of R0 is obviously much better than R1. Increasing resection margin width was independently associated with improved median survival, but subsequent studies have shown that whether presence or absence of R0 is more important. Multi-institutional analysis by triennial group that no actual benefit of increasing the margin distance among the R0 patients, no difference in recurrence-free survival or overall survival among patients who had R1 resection margin, wide negative margin or narrow negative margin. This is an old paper, but till there was a trend, some nomograms were developed based on R0 versus R1, but the consensus guideline is that the goal is R0 followed by adjuvant therapy for positive or narrow margins, but no prospective data clearly available. Vascular resection, about 10% of patients may require vascular resection to achieve R0 margin. In a last study, 14 patients underwent major vascular resection, portal vein 5, IVC 9, not associated with increased risk of perioperative complication or worse median overall survival. Major vascular resection, no increase in perioperative morbidity or mortality or worse oncological outcome. If we look at why this this is an important disease, because the survival, if we see, decreases with the stage. This is based on the current CR data. Stage 1A is 57.4% 5-year. Stage 1B is 44. Stage 2 is 30. Stage 3A is 24. Stage 3B is 12.4. And stage 4 is 8.6. The current literature is focusing about how we can improve the survival in this stage 2 to stage 2 and stage 3 disease. The role of NAT mainly revolves around these stages. Stage 1, it's clear. Stage 4, it's clear. So the survival prediction nomograms are developed. This is one of the recent one, which takes into account the age of the patient, T stage, presence of metastasis, grade of tumor, lymph node ratio, and the total points are calculated, and 1 year, 3 year, and 5 year survival can be predicted based on the presentation and even after the resection. So before coming how the NAT and what is the biological behavior response to chemotherapy in this bile duct cancers, once upon considered chemoresistant, 2 important trials have come One is the famous Belcap trial published in Lancet Oncology. Though it has shown that, to clear that, this paper includes all bile duct carcinomas. There are some perihilar, some distal, some intrahepatic, but it's a multi-institutional study. And it has shown that adjuvant capecitabine following surgery with curative intent for patients with biliary tract cancer improves overall survival. But this they have initially reported per protocol analysis, and the intention to treat analysis was not in favor of this. Subsequently, when they have done the long-term analysis, they have shown that capecitabine can improve overall survival as adjuvant chemotherapy after surgery, and it should be considered. So subsequently, it is included in the guidelines that after a curative intent resection, capecitabine can improve the overall survival. Similar study recently published in from Japan, again in Lancet, that they have considered S1, which is a mixture of 3 and chemotherapeutic agents from the Ariels group, and 3-year overall survival was in the observation group was less than the S1 group, and a significant improvement in survival was suggested in this study on intention to treat analysis. Adjuvant S1 could be considered a standard of care for resected biliary tract cancer in Asian patients. This is the major message. I won't go into the details as the topic is more on the neoadjuvant therapy. So what has changed over the last few decades is the neoadjuvant therapy in GI malignancies. Clearly established role of preoperative radiotherapy in esophageal cancer, translating into improved survival and resectability, published in NEJM twice. And then the most important in our specialty is the pre-op PANC trial, which shows the benefit of neoadjuvant therapy followed by surgery in resectable as well as borderline resectable pancreatic cancer. So if we see why NAT is important, this is a JAMA paper which has assessed the trend of NAT over last about 12 years in USA. Definitely cholangiocarcinoma is not included, but there is the trend in esophagus, then pancreas, is the role of NAT is rising. So rationale of NAT, why NAT is important. In ICC patient with tumor which is intrahepatic and there might be extrahepatic microscopic metastasis, NAT control the, here we can control the microscopic disease, then patient undergoes cold surgery followed by surgery subjected to adjuvant therapy. This is to take care as a multi-modality approach to any cancer, to take care of the micrometastasis as well as the tumor locally, and again subjecting to the systemic therapy. So what are the potential advantages of neoadjuvant therapy reported in literature? First is tumor downsizing, second is conversion of unresectable to resectable disease, to increase the rate of R0 resection, more appropriate selection of patients. NAT as opposed to adjuvant therapy helps ensure the receipt of multimodality treatment as a proportion of patients undergoing resection in hepatobiliary malignancy are not candidates for adjuvant therapy, or they lost the window of opportunity and intended treatment is not achieved. So tumor downsizing and conversion of unresectable to resectable disease. The evidence from a BGS paper published 2018, this was the study design, total 186 intrahepatic cholangiocarcinoma, out of them locally advanced were 74, resectable were 96, were subjected to resection, and metastatic were 16. Chemotherapy was given. Second evaluation for resectability found among them 39, 53% only resectable, and no chemotherapy and no patients were eligible for resection. 35 subsequently subjected continuation of chemotherapy, and these 39 patients underwent chemotherapy followed by surgery compared to 82 patients who went for upfront surgery. So this is the baseline data. If we see, the patients who were presented with locally advanced were younger, they have higher CA99, they have higher incidence of vascular invasion, as well as advanced stage. So the median survival of patients who had surgery after chemotherapy was 24 months, and that of patients who had surgery upfront was 25%, was not statistically significant. But if we see the B group, B part of this year, a patient who undergoes chemotherapy alone have definitely much inferior survival than the patients who had surgery after neoadjuvant therapy. This is important, but it sounds that there is no difference, but this is a proportion of patients which were not suitable for surgical resections who underwent neoadjuvant therapy, then deemed to be resectable, and then got the benefit of surgery, which got translated into the survival, which is comparable to the survival with patients who had resectable disease to start with and underwent upfront resection. So whether the neoadjuvant therapy translates into increased R0 resection rates or more appropriate selection of patients, this area is a bit a gray zone because the proportion of patients entirely who received neoadjuvant therapy is much less than the entire cohort, and usually patients, as I discussed earlier, who are unresectable to start with are given NAT, and the patients who are upfront surgery are obviously more resectable. So whether really it translates from into R0 is difficult, but I will show another paper, neoadjuvant chemotherapy for high-risk intrahepatic cholangiocarcinoma, published in HPB. Does pathological response mean better outcome or whatever, whether it translates into natural selection? So 45 patients in this study received NAC followed by hepatectomy. Out of them, 32 were stage 3 and 6 were actually stage 4 at the time of diagnosis. Major response as characterized by mRECIST was observed in 39% of patients, but they have received longer chemotherapy cycles. The various regimens were used, but they were not associated with the response rate. Median recurrence-free and overall survival were 11 and 45 months. And so they concluded that pathological response to neoadjuvant therapy is not associated with improved survival. So on the point whether giving neoadjuvant therapy gives us an opportunity, whether we are selecting patients with a better biological, is not clearly established. Another paper with a neoadjuvant chemotherapy for IHCC. This is also a recent publication in high-risk disease. Patients with resectable ICC undergoing surgery over 2006 and 14, total 881 patients with ICC. Only 8.3% has received neoadjuvant. Median follow-up was 50 months. No difference in adjusted survival with neoadjuvant chemotherapy, but patients with stage 2 and stage 3 disease, NAC showed a trend towards improved survival. Median overall survival of 47 months versus 25 months, and 5 years overall survival of 34 to 25 months in the upfront surgery group. Significant survival benefit in the propensity score match was shown with a p-value of 0.02. So now this is another interesting paper. This is published in Cancer 2022 with systemic therapies associated with improved oncological outcomes in resectable stage 2-3 intrahepatic cholangiocarcinoma based on the US National Cancer Database, and it's recent over the past decade. What they have done is they have almost in the registry, they got 30,000 patients. Some of them have stage 4 disease or no stage information, so 13,000. So finally, this cohort includes about 2,800 patients. So if we see the treatment utilization, in the recent years, there is increasing use of neoadjuvant therapy. But if we see that survival of NAT followed by surgery is comparable, then no surgery. Overall survival of treatment strategy with R0 resection, I again repeat, is if we can achieve R0 resection, then the adjuvant therapy and NAT benefit is lost. So the utilization, summarizing this, probably this is the study with largest population. Utilization of NAC in ICC in United States is low, 6.7%. It's more commonly seen amongst patients with larger, more clinically advanced tumors, so there is a bias. We can't compare apples and oranges. NAT demonstrates potential value in achieving margin negative resection. Furthermore, both NAT and AT demonstrate benefit for patients with stage 2 and stage 3 disease, and patients with stage 1 ICC do not demonstrate a benefit from either neoadjuvant therapy or adjuvant therapy. So this is another, we have seen a systematic review, but this is for all cholangiocarcinomas, but I have taken the results what they get for intrahepatic cholangio in this. So there are till 6 studies which are reporting, but not uniform reporting of outcomes in intrahepatic cholangio. 351 patients of ICC were referred for NAT. 133 receiving unspecified regime, gemcitabine-based regime was given in 29% patient. If we see the R0 resection is more in surgical group, not in the NAT group. R1 resection is more in the neoadjuvant therapy group. R2 resection also is more in neoadjuvant group. So if we come at the post-operative complications of these patients, overall 71 patients suffered from post-operative complication. NAT group had an increased incidence of overall post-operative complication. Increased risk of readmission is also noticed, but there was no difference in major complications as per Clevendino grade 3 and 4. There is no difference in length of hospital stay, no difference in mortality. So survival is again difficult to interpret, but who underwent NAT had a longer disease-free survival compared to upfront surgery. Median overall survival ranged from 24 to 51 months in NAT versus 25 to 37 months in patients without NAT. But this systematic review also showed that subgroup analysis, NAT was associated with significantly longer overall survival in those with stage 2 or 3 disease. But if we notice, what is most important is median overall survival in the absence of surgery, chemotherapy alone, is just 7.8 months. So next is whether is it safe to give NAT in the patient with ICC. This is another American study addressing the safety of neoadjuvant chemotherapy for patients undergoing hepatectomy for intrahepatic cholangiocarcinoma. Retrospective study based on the ACS database from 2014 to 18. Total 1500 patients, 700 after matching. NAC group 110. Again, I repeat, NAC group is in all studies is really small. Less complications versus 110 complications versus non-NAC group having 289 complications, not significant. NAC was not associated with worse 30-day post-operative complications. Post-operative length of stay in the NAC group was about 9 days, and similar. NAC was not associated with longer post-operative stay also. So at present, what I feel is the NAT, like other GI malignancies, is coming in the way, but till the proportion is very small, even 10%, and this can be addressed better in future, whether we should go for neoadjuvant therapy. And these are the trials and the results of, I think, one in the abstract form of this Korean trial has been published, which shows that 56% of patients can be translated to a surgical resection, but the details are not yet available. The rest of the trials are awaited. So coming to the conclusion, NAT being increasingly used, but the proportion of patients with neoadjuvant therapy is low in current studies. Stage 1, there is no doubt, upfront surgery is recommended. Stage 2, 3 is the gray area, but definitely there is a room for improvement, and lack of prospective studies and future RCTs will clear the picture. There is definitely selection bias regarding choosing candidates for NAT. Locally advanced or borderline resectable patients need consensus definition for uniform reporting of such trials. NAT downsizing to resectability is definitely recommended. NAT regimens are varied in different studies by the agents and even the duration of the cycles. Thank you very much. So never change a winning game, but always change a losing one.